I'm going to talk about AI, not the way we've seen things yesterday, but a little bit more practical in what we do. So what are the clinical drivers of adopting AI in IO? Well, we'd like to face the procedures that we do, the rising complexity of the procedures in a more appropriate way. We would like to offer more precise tumor targeting, margins, and vascular mapping, if we can. Of course, the numbers of patients that we treat is higher, and so workflow-wise, we have to include the AI applications. And we would like, if possible, to move towards more personalized approaches in our oncologic interventions. Have we got the technology to do all that? Of course, because using imaging, we have a lot of information from radiomics. We have models of machine learning and deep learning that would offer predictive prognostic models and segmentation that can be also automatic. And we have also natural language processing models that would offer automatic reporting if we use on protocol recommendations. Radiomics definitely offer a lot of information in terms of imaging assessment and can identify features that cannot be seen with our eye, like microvascular invasion, for example, and we can offer potentially pre-procedural treatment response prediction. This would be integrated in all our prediction models and would potentially facilitate our workflows. So we'll have quantitative features from our medical imaging that will evaluate size, shape, textural features that cannot be recognized by our naked eye, potentially, and specific patterns that would help us identify if a tumor is ablated, for example, if we have a response, if this is the right treatment to do. In terms of algorithms, we can analyze directly the images and potentially also lead to either via deep learning processes to autonomous segmentation that can be offered by the new protocols. And all this is done because we would like to predict our outcomes potentially. This is the outer, let's say, target of IO. So we would like to offer more tailored treatment, reduce unnecessary interventions, lower healthcare cost, and of course, offer more standardized treatment to our patients. So this would be performed via machine learning protocols that usually divide the patients to responders and non-responders, and we would have models that would train potentially themselves among the variables. But of course, what we always need to have stronger models is external validation. And this is probably the weakest point of training the models. We'll have several classification systems that can be used in supervised models like logistic regression, random forest, or support machine vectors, but irrelevantly to the training model, what is mainly important is the type of model that we select to train and how this is extracted in terms of information. So the input and the variables take a significant amount of importance. However, everything can be included, even potentially clinical features, demographics, and all this is information that will be gathered in statistical analysis and would like to test a model that will offer the outcomes that we would like to assess. So, for example, we had papers in the past, like this one, for example, that assessed the predictive models for treatment of hepatocellular carcinoma. This was based on logistic regression and random forest models that divided the patients into responders and non-responders and used imaging and clinical data and semi-automated 3D segmentation in a relatively low number of patients. However, the model predicted somehow the response with a satisfactory accuracy of 78% and a positive predicted value of 50%. The strongest predictors, for example, in this specific example, was the presence of cirrhosis, which was a clinical variable, and also an imaging variable of tumor signal intensity in the pre-operative scan that was numbered. However, the patient cohort, for example, in this study was relatively low, and we had a sort of imbalance in the training set of responders and non-responders, and the overall quantitative imaging features were relatively simple. So it has some good outcomes, potentially, but we have to have a critical eye on all that. Similar papers. In this one, a little bit more complex, for example, with TACE and EUS, that the information was extracted by manual segmentation and radiomics, and somehow, in a more complex model, we had a probabilistic approach on what is the potential outcome. Or this, with transarterial arterial immobilization, we see more information in model that would be on a convolution neural network-based segmentation, so semi-automatic segmentation with RF model, and could predict potentially which patients would be refractory in TACE with a relatively high accuracy. Similar study that included also features of clinical, with predictive performance of 0.77% and 0.83 on the validation cohort. So from all these approaches, we could see that what was considered as the traditional statistic models that we used apparently have to be overcome by artificial neural networks, and use the statistics that is offered through that as a better prediction model for the survival, potentially, in these studies. And another one here, where we could see in 83 patients with HCC, again, the factors that we assessed are the sensitivity, the specificity, the positive predictive value, and the predictive performance of the model. And another one, relatively older, however, with prediction that went up to 2 years, with good performance, but again, no external validation. So we have a way of assessing our results, potentially, in interventional oncology. We have to have a critical eye on all these models. We have to be astute in understanding if really an AI protocol is what has been promising initially, and as we did initially with the statistics when we approach our medical literature, now we have to be a bit more astute in understanding if the models are really valid or not. We can have a lot of factors, but if we have no external validation, for example, this is relatively weak in terms of outcomes. What other factors can offer AI in I/O? We can use AI for other applications like pre-procedural planning. And this can be done with segmentation, automatic segmentation of imaging, and perfusion-based territory analysis, for example, if we use TACE, and the ablation margin simulation, if we would like to assess whether we have done enough of ablation and would like to tailor that to specific energy source planning. And the margin prediction is quite important because we can use specific convolutional neural network to predict the probability of incomplete ablation, and 3D margin quantification, post-ablation, and all this can be integrated in intra-procedural fusion systems. And we have some commercial systems available, as you may see. So this is from a specific company, of course, and these are products that we have that could be used for fusion, for targeting, for navigation, but also for prediction of the outcome. And of course, this can be purchased, and we have few of these fancy systems that can be used for as predictive model, either for planning or for outcome assessment. Similarly, this one, and all these are products that can be purchased potentially. We see navigation, even with ultrasound, can be used, and this would tailor the specific energy device, or either microwave or cryo or RF, and would identify the area, would suggest whether we need this type of energy or this other type of energy, and would also quantify if what we've done is enough. So these aim to offer biological signature and are able to visualize, at least they claim, a 24-hour thermal effect. And all this is integrated in our clinical practice. And it can also be offered also for taste, and all the commercial devices have offered, of course, the embo maps, as we may see. So this is a suggestive pathway of which is the shortest way, and this comes if you scan the patient in arterial phase, and of course you identify the lesion. This is integrated in the scanner, and the scanner would suggest a pathway that you can either follow or not, and this makes our life definitely easier. We can have a vessel classification of fetal detection. We have predictive model of taste for responder probability, but we also have the automated quantification of lipidol, and of course dosimetry. This is also very important, can be done as a prediction for endoembolization. This is another feature that has to be considered. And of course, for follow-up, we can have segmentation for responders and non-responders. As we may see, we have the radiomics, quantification of potential necrosis versus residual disease. We have modeling on that, but it's not only plain sailing. We also have some challenges because the data sets might be heterogeneous. We have a boost of technology, but we don't know if this really is robust. Limited cross-institutional growth through. There's no true standardized imaging protocols, and what is crucial when we see these studies, as we've seen, is that we need external validation. This would make statistically more important, more robust, and we have deep learning models, but we have to be astute in identifying which are the pitfalls in each study. And I have to comment on that because actually what we've seen previously is that there's an AI hype, and we've seen that in IO we have this range of applications that can be used. However, this is the AI Act from the European Commission that was published in 2024. And this is a very recent paper that is mentioned, Guidance for Risk Management of Artificial Intelligence Systems. So I think a new era is coming now that we come to sort of I wouldn't say an adulthood, but probably teens of the AI that now have to get serious. And of course, we can have a machine learning protocol, fine, it's fancy, yes, but is it really accurate? Is it really what we consider robust knowledge? So we have to, all this has to be included in what we do, and we all have to be, have a critical eye on the outcomes of these studies and these new applications. So whatever we used, from the future, I think, has to have some approval, either CE or FDA. We'll have some specific requirements. Of course, liability and operator oversight is crucial. And there are other factors like cybersecurity and data anonymization for digital data has also to be included. And of course, this has to be somehow integrated into our systems, workflow systems, and all this has to be taken into account. We have a number of future directions. It's very fruitful, the research directions of AI. Of course, are we dealing about potential autonomous needle placement assistant? I don't know, maybe. We will find out. Or adaptive AI-driven adaptive ablation control. Definitely we need the feedback. Multi-omics integration with genomics and radiomics. Yes, this is a possibility. We do that. But as mentioned, we have to have models that are robust in terms of information, foundation models for oncologic imaging, and real-time decision support. So if you, for example, to be a bit more practical, if you ablate a lesion and you've done half of it, then the machine will tell you, please don't walk out of the room unless you do the other half, and say, okay, I mind my own business, and then you begin to litigate with the machine potentially. This might be, I don't know, maybe the future. So if you see in IR in general, we have applications that are involved with decision-making, model predict outcomes. with navigation and with fluoroscopy or ultrasound or CT and MRI. We have fusion that is included. We have robotics. We have virtual biopsy. And all this is amalgamated in what is now potentially AI applications in what we do in our novel and technological specialty, which is interventional oncology. Ourselves at CIRSE, we have given a great amount of importance in interventional in AI, and we have a specific section which is called the Sphere, and this is coming from the Spotlight on AI in IR. And I think this year was very fruitful. I am involved in the program, so we've seen all these new applications, new abstracts. You see a number of things from evaluation of trajectory, bridging radiomics, predicting treatment, even the use of smartphone, assisted CT guidance. So a lot of applications can be used for AI-based for our procedures. So we can take home that it is definitely a rapidly evolving area. Everybody's talking about AI these days, even philosophers. It is likely to change I/O, that's for sure. There's no doubt. On our day-to-day tasks, it will evolve, maybe, potentially, even to performing some procedures or assisting significantly in performing procedures. Of course, it would help in the time that we spend with patients, so it would be reduced, it would facilitate our workflow and what we do, and it would support what we do in terms of evidence-based and decision-making. Of course, we have to consider that the new era will be regulated, and it won't be like the last 10 years that has been just a hype and just an evolution. Now we have to adhere with specific regulations, specific established rules that would somehow ring-fence and benchmark what we do in our everyday practice. Thank you very much for your attention.